Well, I'm sure everyone's aware we just came through One Health Day, and we had a One Health event at the K-State Olathe campus and talked about One Health and how this is related. And one of the things that was really exciting there, we had a lot of young scholars. We had posters from high school students up through undergrad and graduate students who were presenting there, and it was really neat to see all those there. And it got me to thinking about more and more things, and also had the opportunity to present there, and took this a little different direction for here. But that perspective is from someone who was pretty cynical about the One Health term, because I've heard a lot of people using it for their personal agenda advancement. The actual concept of One Health working together is incredibly sound and where we should be going. It's just like everything we talk about, where some go with it. But I believe One Health is the way we move forward. And so this is a view shot by Russians, and it's one of the newer ones with the actual colors of the Earth, etc. I thought it was really a neat view from out in space, but we each come to this with our own unique views. So my view of the world the other morning was that, looking out our back door at the pond and the tree turning right out our back window, and so that was my view of that big globe that day. And we all have our own unique view of what we're looking at. So let's take another opportunity to drill down. Let's jump back out in space, courtesy of Google Earth, and let's look at our side of the globe. And there's the United States in North America. We're going to zoom in on the United States, and now we're thinking about a personal example of where antibiotic stewardship happens. And it's about stewardship, and we'll come back a little bit later about continuing to emphasize the common ground between stewardship and infection prevention in the human side, and stewardship, which includes both as we use it in the food animal side. So the United States, drill on down to Kansas, which is the center of the United States, you all know.
Center of the world.
The center of the world. I was kind of thinking that too. And now we're down to Pawnee County, Kansas. Right? And that's a little county out there that I grew up in. We think we're western Kansas. Dr. Sparrod think we're eastern Kansas. We think we're kind of northern, but when you go visit Washington State, they ask me what part of the South I'm from, so it's all confused. But that is this town of Larned that I moved to when I was 4 years old, when Dad graduated vet school, and set up his practice there. And now we're going to zoom in on the town of Larned, the wonderful metropolis that I grew up in, and terrorized those streets, first with a bicycle and then a 64 Nova, leaving scars across the town. So there's the veterinary clinic I grew up in, and it's now owned by Dr. Burdett. My dad founded it, and I practiced there with Dad and Dr. Huck and Dr. Burdett, and then Dr. Burdett took it over, and veterinarians worked with him. Now his daughter's there, so that's where the veterinary clinic has been for a long time. There's now a second veterinary clinic that serves the community south of town, Dr. Frick. Sorry, I had this name wrong. I had my professorship. The dentist's office, right? Right there. There's the critical access hospital and doctor's office. So that's a new critical access hospital, several years old, that the system that owns it has now been bought by the University of Kansas healthcare system. We have a very large number of these smaller critical access hospitals, 25 beds or less, throughout the new one. Dr. Sparrow, who will be on later, comes from Ashland. It has a brand new critical access hospital. We're so fortunate to have that there and some great care. We have a long-term care facility right over there. We have a pharmacy. We have another doctor's office, and right off to the south there, we have a large feedlot, another one on to the south. And we have a state psychiatric hospital and facility out to the west there, to your left, which also would have antibiotic prescribing. So as we look at where antibiotics come into this community, there they are. And those are places where we would say stewardship should be practiced. There's also Great Bend, Kansas, 20 miles away, that people go to for care. A lot of people go to the hospital up at Hayes. Prescribed antibiotics can come into our community from there. So there's a lot of things in this microcosm, but we're going to drill in one deeper and see if you can recognize this young veterinarian with a patient up there at that veterinary clinic on the top of the screen. We're going to hit an exam room there in 1988. That's like 10 years ago. That picture was taken, and that was actually a corgi with autoimmune hemolytic anemia. We got it through that bout, but 6 months later we weren't as fortunate. But that's me with a patient there a year out of vet school, and I can assure you that antibiotic stewardship or resistance was nowhere under that much thicker head of red hair. Would I be thinking about the community, the county, the state, the country, or the world in my interaction with that patient? We're going to talk about that concept of getting into those relationships, because we can talk about national trends, we can talk about sales, we can talk about anything we want to on data, but the act of antibiotic stewardship and the cause and the solution of antibiotic resistance lie in literally billions of these interactions per year. That's where it lies. And I might as well be looking in my next practice life. We had 35 feedlots our practice took care of that fed 1.5 million head of cattle a year. And now there's practices out there that'll deal with, a third or a fourth of the fed cattle in the U.S. There's practices out there that take care of a huge percentage of the pork production. We could get most of the poultry veterinarians in the United States in this room. So when you look at that, those stewardship scales can get larger and larger, but still this is where it happens. So how could we interact with this? Well, we could start the monitoring. There's the clipboard, and everything I'm doing gets monitored with feedback. And one of the things we also have to pay close attention to is that we celebrate the achievements of large institutions with the ability to have control of formularies, but we don't confuse that with the solution or the ways we interact with community practice on the human side or in veterinary practice, which very, very closely resembles community human practice. We have increasing instances on veterinary and in both veterinary and human medicine where we have centralized control of a lot of community-based practices. We have large companies that own a large number of veterinary practices. We have the movement into systems of veterinary or human practices also. Third-party payers are something totally different on the human side, obviously, than the veterinary side. That is a way of instituting control and monitoring, and if you want to get paid, you need to do this feedback system, which is not present in veterinary medicine. The equivalent in veterinary medicine would be marketing chains. Although the challenge with the marketing chains is they have a totally different incentive than does CMS. Right. So they're kind of alike, but not really alike. The other thing is that gavel up there, and we can start putting regulatory oversight in, regulatory and legislative oversight. So you're well familiar in this room with Senate Bill 27 in California. You're familiar with animal welfare legislation around the country, and we're familiar with antibiotic use legislation at the state level. And in the case of California's bill, goes beyond the federal legislation there. Or we can just put a line there that filters where formulary controls that. And again, in larger systems on the human side, they're able to have control of formulary. They have hospital review boards based on the priority of the antibiotics, where they review your ability to get them. And humans are a very inventive form of life. If the review board goes off duty at 10, at 10:05 they'll put in the orders so they can get them, and then they'll apologize the next morning. Or you use combinations of antibiotics to try to achieve the same spectrum that you would with one medically important antibiotic. And we'll come back to that a little bit later. So it really gets crowded in that room, doesn't it? With all of these things that we consider. So that could be a physician talking with a mother with a pediatric patient, all of those types of things. And the further away we get from that interaction, the clearer it becomes what we should do. And when you get down in those interactions, the clarity of big picture, long-term thinking becomes a little tougher. So I still go back to Rushworth Kidder. And I share this with the vet students. I've shared it with my family. A tremendous book on how good people make tough choices. And it was formative to me when I read it. And he brings up the difference between a moral temptation, which is we would say it's right or wrong. If I walk out and my pickup's gone, I think we'd pretty much agree that's wrong, right? To take that without permission. And we call that theft. There's a law against it, but just because there's a law against it doesn't mean that's the only reason it's wrong. He also talks about ethical dilemmas. And he proposes that any decision we make can boil down into one of those four categories. And his proposal in that book is you think ahead to how you handle those. Well, you'd say, well, I'd always be for truth. Yeah, till it's your kid or your boss. Justice versus mercy. The individual versus community and short-term versus long-term lay right at our feet in this meeting. It's absolutely what it's about. So which is it? As a prescriber, my prescribing thought process is dominated by avoiding the probable or possibly rare but catastrophic short-term adverse outcome for the individual with whom I have a relationship. Sometimes a shorter phrase for that is cover your butt. The other one is my prescribing thought process is dominated by avoiding long-term adverse effects on the community. Which one is it? How do we blend those, right? So I came back from a PACCARB meeting and I was with some new information and I was heading to another one. And I was in the security line heading out of Manhattan, Kansas International. Got 2 jetways now. And I was getting ready to walk down one of those jetways, and I was a gentleman there in line, and we recognized each other from some places we are in common, and he said, where are you going? And I said, well, I'm heading out to the Presidential Advisory Council on Combating Antibiotic Resistance. And I go, well, what are you doing? Well, we're heading to a internal medicine meeting. I'm an internist, human internist, and with him was a pediatrician. And so this is like the pediatrician, the veterinarian, and the internist walking to the bar, right? Well, so I explained to him what we're doing with PACCARB, and he said, well, that's interesting. I said, well, last time we learned that it depends, but one of the subject matter experts talked to us and said only 1 in 5 human bronchitis cases would need antibiotics. Actually, very high on the viral spectrum. People come in, their chest hurt, they've got a fever, expect an antibiotic, and the data would say only 1 in 5 actually would benefit from an antibiotic, and we've heard some that would say almost none. And he goes, when you can tell me which is the 1 and which is the 4, I'll stop giving them antibiotics. And fair enough, because there was someone who was seeing the patient and looking him in the eye, talking to me, hearing about it from a 30,000 foot level, and pulling my hat down around my ears a little bit about, you come be in my shoes, you decide which one comes back the next week, and you could have headed off something catastrophic with an antibiotic at the right time. It's not that simple. Now, delayed prescriptions, Einstein level thinking. They do. There's some really cool stuff where you can give a delayed prescription in 48 hours. You can go get it filled. For our veterinary students, I tell them that's why they created rechecks. Right? That's why they created the phone, so you can call and see how the patient's doing instead of automatically doing that. But it's a whole nother thought process. To me, this slide addresses the real issue at the prescriber level, that you step out into the realm of saying, I'm going to accept a little risk here that we could have avoided something with an earlier antibiotic, with the thought of of preserving it. So for us, it might look like an ethical dilemma between the physician-patient and the veterinary client-patient, but from the outside, it might surpass an ethical dilemma, and that's just wrong. It's wrong to use antibiotics in food animal production because we need to preserve them for people. It's wrong to, you name it. So the further you are away from the negative consequences, the more it becomes a moral decision rather than a dilemma. And that's one of the issues we see. So at a personal level, this was a bag of vancomycin hanging on the drip set for my son Kyle when he had his MRSA infection in his leg that was threatening his leg, which we'd saved a year before. And great care at Stormont Vale, they saved his leg, saved him. But when he was on that Vanco, his leg that was started to streak, and his temperature was rising, and there was questions of what was going on. And as a parent, my reaction was, you bring the house. The heck with stewardship, you bring the house. This is my kid, you bring the house. Linezolid, let's go clean out the closet. Right. I had a relative in after a cancer surgery procedure, got a post-surgical infection, and I always thought AB therapy stood for antibiotic, and I found out it stands for atomic bomb, because as they prescribed 3 different antibiotics at once for him on top of the ones he was on, that's what they explained to him, that this was like an atomic bomb on those bacteria, and they were bringing the house on that individual patient so that there was almost no chance that something escaped, and they were unsuccessful in the culture because he'd already been on Pip-Tazo, and they were going to ramp it up. So those types of decisions, that's where it actually hits the road. What are we going to do? What are we going to do to prevent this? Prevention and control practices in animals, in food animals. What do we do to control that while we find other ways to prevent it? It's not so clear when you're down in the weeds when those things happen. And that's, so would a formulary control that? Whatever. But when it gets personal, all things change. So there are some equations I'm pretty sure of, and I keep adding to this slide. Fairly confident in these equations that they guide us. So I think that would be the sum of use. There's effective use and ineffective use. If I didn't actually need it, it's ineffective, but sometimes that's armchair quarterbacking. Why would we use something that's ineffective? Because it's perceived effective or perceived as needed, or it's I don't know what else to do use. They want to leave with something, I'll give them something to leave with. Right. I really like the viral prescriptions, the prescription products where we can say, here's the check mark of what you want to do. Fluids, rest, anti-inflammatories, cough medicine, bang, bang, bang. Here's things you can do. They leave with a validation that they have their need for therapy, their illness has been recognized. There's a little equation we forget the second part of. We talk about antibiotics, and it's equally or is more the the bacterial population that we're dealing with. Whether it's microbiota, whether it's the pathogen population, that's the other part of the formulary or the formula. We get talking about this antibiotic does this or this antibiotic does that, when in reality, using something as mundane as good old tetracycline can co-select for resistance to something much higher up our scale of importance. So just resting comfortably because we're using a lower importance antibiotic, to me, has become rather meaningless to me. And it also reinforces the need to discuss the fact that we are ignoring the need to go back and revisit the basic therapeutic regimens of our most basic antibiotics, Amoxi and urinary tract infections, what they've discovered about how brief the regimens can be in the majority of them, in a majority of cases in some studies. Revisiting duration, we've really looked at this in our journal club with our group, and 10 days, where 10 days comes from is crazy, right? It's the power of the number 10. Let's go for 10 days. Do we really have clinical data that that's how long the exposure needs to be for? And the answers, in a lot of cases, is no. The first failure is failure to prevent the infection. We get completely away from the discussion of right antibiotic duration, the right regimen, if we just are successful in preventing the infection at the same time, or the first time. And the second failure is failure to appropriately treat it with the right antibiotic. As a clinical pharmacologist, I always try to remember that resistance in some cases means we have no options, but in a lot of cases it means we are delayed in getting to the correct option. Because we start with the empirical therapy and it is resistant, and now we're 2, 3, 4 days down further into the disease process before we receive the correct therapy. And then the ultimate therapy failure is bacterial population exposure without achieving the desired effect. And that goes back up to the perceived effective use, or I don't know what else to do use. First thing's infection control. Infection control, infection control. How do we do that? How do we, from the veterinary side and food animal production, how do we select for populations and provide the husbandry for those populations to drastically reduce their need for antibiotics? It gets complicated. This is a food animal production system, and all the things on the left are what feed into it. It's incredibly complex, and I would challenge you to give me one of those categories feeding into that production system that is not changed in availability or cost in the last 10 years. So now we're going to fire up that system and get it running, and immediately two characteristics come out: efficiency and animal welfare. And as a food animal veterinarian, I went through a phase of thinking efficiency was a dirty word, and I am over that. The efficiency of food animal production in this country is nothing short of amazing. And we do have people that incorporate and embrace technology, and they embrace economies of scale in order to stay in business. And when we talk about sustainable, we have to define sustainable. And for a lot of the people I work with in production, a big part of that is I'm in business again next year, which is a real challenge. The outputs are food, and then our interaction with the environment. And one of the reasons we're here today is what's the interaction of that food and the environment with human health. And if we pick one little piece out of that technology that are antibiotics, we can measure effects on efficiency and on animal welfare. And then we're wondering about what effect that antibiotic use has on the food and in the environment and how that interacts with human health. It becomes a pretty complicated system. Now we're going to measure. Oh, I forgot that little yellow line there. That's kind of important because that's whether or not that food system's there next year to supply the food. The other thing I'll point out is that producing food without a profit motive is called gardening, where I come from. We're going to start measuring, and we can measure resistance or presence of bacteria on the food. We can measure the use of the antibiotics and try to correlate through the system to how those are related. We should also be measuring welfare, and we should also be measuring efficiency. So there's two sides to that argument. As a veterinarian, I do not like it at all if I have an animal with an infectious disease that I could treat with an antibiotic, and I'm prohibited by doing that because of market access. On the other hand, it's right that we do everything we can to not have to use the antibiotic in that animal. So there's two things that are right there that we balance and we move forward. I would propose that we also need to measure these. If we're really going to look at how things go, we need to measure the inputs, we need to measure the whole system. Systems thinking and getting our hands around incredibly complex systems is one of the toughest things we do, whether it's a health system, a health provider system, whether it's a distribution system, whatever. It's some of the toughest things we do. Dr. Hope will be talking with you tomorrow from our group about some of the things we're doing in our monitoring work, and Dr. Lubers will be talking with you, I think, on Thursday. And we're very actively involved in this, and we have burned up a lot of whiteboard markers trying to figure this out. It's a fascinating system. There's a lot of questions. I want to turn this a little bit to the U.S. National Action Plan for Combating Antibiotic-Resistant Bacteria. And this started, the first plan was from let me get this right, 15 on to 2020, this was what the NAP consisted of. Laudable goals, really good things to look at: slow the emergence of resistance bacteria, prevent spread, strengthen national One Health surveillance, advance development of use and rapid and innovative diagnostic tests. And one of the really big learning curves for me, the human medicine is just like veterinary medicine, is who's going to pay for these tests. And if you get a new test approved, getting it to be paid for by third-party payers is a whole nother step. That's the next big obstacle to get that test paid for. Accelerate basic and applied research and development of new antibiotics, other therapeutics, and vaccines. Finding antibiotic alternatives is a big, heavy lift, especially if we expect the efficacy of an antibiotic against a susceptible infection. The bang of an antibiotic against a susceptible infection is dramatic. It's huge. Many of the others where we're trying to shift immune systems, we're trying to move other things, it's hard to get the same big boom when you use them, and especially when their cost of production requires a price point that may be closer to an antibiotic. It's the realities of putting those things on market. Completely in support of those coming. The other thing about developing new antibiotics is I think that $250, $350, $400 million on the animal health side for one is a lot of money. $2 billion with a buh on the human side to get an antibiotic to market. And then if the incentive for that is it will be held back as a reserve highest priority antibiotic, we've got something the economists call decoupling, or the market failure, right? So we talk about decoupling, we talk about incentives back to those. You've probably all heard of the CARB-X program, which helps things be developed. It's incredibly time and money expensive to bring these new things to market, and looking internationally and seeing what's out there. So on the PACCARB, there have been some reports, and I invite you to go to the website. Everything I'm going to discuss here is straight from documents from the PACCARB. This was the initial assessment, our first report on the National Action Plan, and in it, these were 6 overarching themes that the PACCARB thought required further action by the U.S. government: One Health, the lead federal champion, coordination of federal response, resources, all comes down to money to move this, right? Critical partnerships, and then economic incentives for developing these new technologies to help us. We've entered into a One Health definition, multiple disciplines and professions working locally, nationally, and globally to achieve optimal health across all of these areas. It's stated rather obvious that microbes do not respect geographical, political, or species boundaries, and I've also never seen them read a drug label and say, oh, I'm on the label, I need to die. It hasn't happened. Relationship between humans and domesticated animals, central principle. It's a hard thing to put a pin in it and say this is exactly what happens and where. One Health is seen as an organizing principle to be used to better understand resistance and to generate new interventions, understand transmission. All 5 working groups that we worked through for that report stressed the principle of One Health, but the efforts in animal and human health remain largely disconnected, which of course is a major goal of this group here, to work on that connection. And I can just tell you personally from my experience on PACCARB, the learning and understanding of what's going on the human side, and I think vice versa, has been unbelievable. It's been one of the best educational opportunities I've ever had to learn and listen from a lot of talented people we bring in, and a lot of talented people that have served on our group. Contamination of the environment. The environment's a really big thing. We had a great session on the environment with some talented people that came in, and one of the things that stuck with me, if you wanted to build the ultimate environment for horizontal gene transfer, build a solids digester at a human treatment plant. The perfect environment for that transfer. And we also have manure discharge from livestock systems that we treat in lagoons and all those types of things, so a really big important part. There's multiple reports and recommendations. You can go look at past meetings. There's archived webcasts, PDFs of presentations, a lot of really interesting stuff. Whatever you're interested in, you'll like to see. Right now, our new charge from the Secretary of Health and Human Services is we are to look at the current action plan and comment on what needs to be added from our viewpoint for the 2020-2015 National Action Plan for Antibiotic Resistance. We are going to be needing help. We will be at our next meeting having a wide variety of stakeholders come in and talk to us about what they see as needing to be added to the National Action Plan. There's the opportunity to present public comment at that meeting. Also, watch the Federal Register for a notice on how you can put in written comments on where you or your organization feels we need to change, add to, or modify the National Action Plan for the next 5 years. So we'll be asking for that. We want as wide an input as we can besides just what we think, and that's how we're moving forward. So this is the definition of antimicrobial stewardship I'll leave you with from the Infectious Disease Society of America. And this is a great concept about applying antibiotics. Again, as a veterinarian, I consider infection prevention and judicious use of antibiotics all rolled together into one antibiotic stewardship definition. On the human side, we talk about infection prevention and we talk about stewardship in the use of antibiotics. So we're talking about the same thing. We realize it's all rolled into one, but we tend to use a little different terminology, so it's important to realize what we're talking about and how. One of the things, again, from the learning curve is hand hygiene in hospitals. You know, it's like some of the basics. We still have room to improve on one of the basics. And Nadine Hagmeyer, who works for the Kansas Foundation for Medical Care, which is our contractor with CMS, she's a past practicing nurse that's now working here. I would not want to be the physician that didn't wash my hands when I walked into a room with Nadine in there. She's passionate about it, and she encourages us that if your caregiver walks in without sanitizing or washing their hands, you tell them to go back and do it and then come back in. But those types of basics, the heartening part is there's still a lot of room for the basics, the real basics that we can work on to advance us forward with that. So I hope that helps set the stage for what we're doing over the next few days about where we are, the concept that the stewardship, the prescriber behavior happens at that individual level. How do we help change that to change it from short-term, immediate avoidance of the worst-case scenario to a long-term view so that we have these tools 30, 40, 50 years from now that we can still intervene like they did with my son, who's now happily running around starting his PhD in medicinal chemistry. So with that, I wish you a great meeting, and we'll go forward.
We've got time for just a few questions. We want to keep moving, and I want to kick it off. Dr. Apley, as you work across disciplines, you're addressing this from a multidisciplinary approach and dealing with human health. And tell me, in your experience, what's your biggest challenge in terms of communicating? Where are the biggest breakdowns in terms of communication as we deal with this across disciplines?
A uniform belief that there's a problem, and that the person I'm talking to could be part of it. I think it's pretty uniform that we pull back and can easily see what other people are doing wrong, but it's pretty hard to look in the mirror. I think that's the biggest challenge. And going out and talking with grassroots people, unfortunately in today's environment, taking at face value some of the challenges we face is really difficult.
We'll do two questions and then we'll keep moving here.
Very interesting. So I read about this study that they do in humans where it's behavioral science. So the thing that it has the best impact on antibiotic use in GPs or general practitioners is to do peer pressure. So peer review and pressure on why the guy next door is using less antibiotics. Do you think that, keeping that in mind, that if we could measure these could have an impact on what we do in medicine?
I think measurement's a part of it. I think it is, and I'm a real fan of benchmarking, so people can look at the practices of others and learn from what's being done differently, especially with preventive practices. We're all people. We all experience fatigue. On the human side, they do studies on adherence to stewardship guidelines. And if you want your physician to have the best chance of giving you whatever you want, go in from 3 to 5. They're fatigued just like us. The human behavioral aspect in this, it's over 50% of it. And the other thing is talking with some really talented microbiologists, laboratory personnel with some clear guidelines to share. Not always well received by the physician that they would deem to tell them what to do. There's a whole lot of human behavior in it.
Any other questions? If not, Dr. Apley, thank you very much.
Thank you.